But I think it's 2 more minutes to go, right?
Yeah, 1 more minute to go. So this is the presentation, Anna-Karin, that you were asking for. And I think what we will just say is each of you can speak up and tell the audience that you're representing Sweden, Norway, whatever. And then we will go into the presentations, okay? And there are now 41 participants and 1 minute to go. I have now closed my door because my dogs have a tendency to bark when someone passes outside. Right, okay. We are currently 48 participants and I think we're ready to go. So very welcome everyone. This is the Nordicast webinar number 2, online seminar on the new definitions of SINR and the use of ATU. The seminar will be recorded and that means that we will put out the recording on the Nordicast website eventually, probably post weekend. You can find it there. So apart from a short general presentation on the EUCAST UI and a short presentation on the area of technical uncertainty, there will be reports from the Nordic countries. And I have put them up in the order of slide submissions. And the last slide came in about 7 minutes ago. Iceland is last because I haven't had any slides from Iceland. I'm not sure whether Christian is with us, but we will see. So who will speak for Denmark?
That will be Ulrik Justesen from Odense.
Very welcome, Ulrik. And who will speak for Suomi, Finland?
Kaisu Rantakokko-Jalava from Turku.
Welcome. And for Norway?
It will be me, Karianne Wige Gammelsrud, and also Kristoffer Lindemann.
Very good. And from Sweden?
It will be me, Anna-Karin Smekal at Karolinska University Hospital.
Great. And is there anyone from Iceland online? It's too early in the morning for Iceland. So just to tell everyone that you can unmute your microphones. I ask you to mute them if you're not going to say something and to mute them again when you have said something. But you are very welcome to say something. And it should be possible for you. I've set it up so that everyone is now in control of their own mute button. So just to lead into this, we have an hour and a half to deal with this, present and discuss. As you will all know, in 2019, EUCAST changed the definitions of S, I, and R. And the changes for S and R were so small that you haven't really noticed much. It's the change to the I definition, which in some ways upset some people at least. The essence of the change was that EUCAST decided to emphasize that phenotypic susceptibility testing is quantitative. So you can say more than, less than, more sensitive, less sensitive, more resistant, less resistant, and also that all breakpoints are dependent on exposure. The new definition was therefore susceptible increased exposure. A microorganism is categorized as susceptible at increased exposure when there is a high likelihood of therapeutic success because exposure to the agent is increased by adjusting the dose regimen or by its concentration at the site of infection. And if you compare that with the definition below, which was the old definition, you can see that a number of things have been taken out of the definition, such as uncertain therapeutic effect, which is really the responsibility of the company and the EMA and EUCAST, and also the uncertain, uncontrolled technical factors, which we have instead made the laboratory responsible for. And just to make very sure that everyone is aware of the difference between dose and exposure, because some people say, why did you not say susceptible at high dosage or something like that? And here's the reason why. Dose is the amount of drug given to the patient. And you can increase the dose by two different means. You can either increase the individual dose, such as, for example, from 1 gram times 2 to 2 grams times 2. Or you can shorten the interval between doses. So you go from 1 gram times 2 to 1 gram times 3, or 1 gram times 4, or 6, etc. Whereas exposure is the amount of drug which the infecting organism is subjected to at the site of infection. And exposure can be increased by any of the following means. You can increase the dose over time, which brings you right back to the topmost two options. Or you can change the mode of administration. You can go from oral to IV. That will normally, not always, but normally increase the concentration at the site of infection. Or you can go from IV injection to IV infusion, which will, for beta-lactams at least, normally give you 1 dilution or maybe 2 dilutions in the MIC. Same dose, same mode of administration, IV, but instead of injections, you go to a continuous infusion or a long infusion over 2 to 4 hours. That will give you more exposure for beta-lactams at the site of infection. And then we often take advantage of the pharmacokinetics of the agent, which means that some agents concentrate in specific body fluids or tissues, and without fiddling the dose or the mode of administration, we can actually reach very high concentrations at the site of infections just by knowing that the pharmacokinetics of this agent are such that it will be concentrated at the site of infection. And you would normally think of urinary tract infections, but there are other sites. There are agents like, for example, spiromycin, which are concentrated in saliva. So there are other ways in which pharmacokinetics can increase the concentration at the site of infection. The I category is used to signal low inherent sensitivity of some species to an agent and to compensate for low-level resistance mechanisms for other bug-drug combinations. To the left here, you have Haemophilus influenza, which is superbly susceptible to quinolones. And you can see that the MICs are below or equal to 0.06, unless there is a resistance mechanism. On the other hand, you have Staphylococcus aureus to the right, where the whole wild type is to the right, and the ECOF is actually 1 milligram per liter. And between the two populations, there are almost 2 10 logs in difference, and Haemophilus will respond to very standard exposure, whereas Staphylococcus aureus is in need of a decidedly increased exposure to respond to ciprofloxacin. Strep pneumo, on the other hand, is so far up that not even with an increased exposure will it respond in any systematic way to ciprofloxacin treatment, and breakpoints have been taken away for that reason. And basically the whole thing is very simple. If you don't give an agent, you will not have an effect except possibly placebo effect. If you give a relevant amount of agent, you will have effect. If you give too much agent, you will have effect, but you will probably also have toxicity. So it's all very relative, and all breakpoints are dose dependent. The new definitions describe 2 levels of sensitive and 1 level of resistance. In the old system, we had 2 levels of resistance and 1 level of sensitive. And that's really what we wanted to change. In preparation for the change, all countries were addressed on numerous occasions. Between 2015 and 19, there were a number of consultations, public, all national AST committees were addressed specifically. All the concentrations are still available on the EUCAST website. All the responses from EUCAST are available, and anyone who's interested can go and chase those on the consultation page. And some of those are way down the list, but they're still there. So EUCAST decided to keep SINR. Why? Because a poll among colleagues, national AST committees, ESCMID, EMA, ECDC, etc., showed that more than 80% of everyone who were asked, and there were more than 100 responses, were in favor of not changing the I. One of the reasons being that companies signaled that it would take them a long while to change from I to another letter. And also LIS systems signal that this was not something that was easily done. We could see how during a period of at least 5 years, we would have I's and new letters floating about, and that would probably increase confusion even more. So we decided to emphasize the relationship between the breakpoints and the concentration at the site of infection, to revise breakpoints so that breakpoints correspond to the new definitions, to remove uncertain effect and uncontrolled errors from the definition, and to place the responsibility for the respective where it belonged, and to task clinical laboratories with the responsibility for uncontrolled errors, irrespective of origin, and for EUCAST to help identify these and form strategies for difficult areas. The drivers of exposure, dose and mode of administration, and the pharmacokinetics are shown in the EUCAST dosing tab. Dose and modes of administration are both listed in order of the agents, and the agent is in the left-hand column. The standard dose and standard administration is in the next column, high dose administration in the third column, and then there is a separate column for uncomplicated UTI. In the rightmost column, there are comments, many of which will now disappear because we've actually introduced the meningitis breakpoints after consultation during 2020. These will be introduced into the table during, or rather at January the 1st, 2021, so in 1 month. It's important to realize that the S less than or equal to 0.001 is not a real breakpoint. It's an arbitrary breakpoint, and it's there to prevent anyone from actually getting an S during testing. And the same with the zone diameter breakpoint of S more than or equal to 50 millimeters. We sometimes get questions on how do you expect us to manage that? We don't expect you to manage that. It's to prevent you from managing that. The most discussion following the change is with Pseudomonas aeruginosa. And you can see here, I have copy pasted all the I categories that were the result of the change. And you can see the arbitrary S less than or equal to 0.001. And the R breakpoint hasn't changed. The only thing that has changed is that the wild type for Pseudomonas for these agents is now categorized as susceptible increased exposure instead of susceptible normal exposure. And these are the agents that are currently reported, where the wild type is currently reported as S. And of course, the fear is that a lot of people will start using meropenem instead of one of the other drugs. And that is probably one of the things we will discuss today. So, what to do in a country? Well, first of all, communicate with your national AST committee, and that's basically what we're doing today. Follow the EUCAST recommendation, introduce the EUCAST breakpoints, and take steps to explain to your colleagues, both locally and nationally. And report susceptible increased exposure and add a comment to explain. And over the last couple of weeks, when I've had seminars with many countries, I have seen many good comments pass by, and they're all geared to explain that susceptible increased exposure is just another level of susceptible, and it signals that you need to take care of your dosing. In several countries, I have now also seen a stewardship model, if you like. They say that we have introduced the EUCAST breakpoints, we performed the testing, we categorize according to the EUCAST recommendations, but maybe we do not need to always report. So for serious infections, you always report and you add a comment as per one above. But for less serious infections, the stewardship angle would be to say, well, we probably shouldn't treat all Pseudomonas isolates, and we probably should not treat all Haemophilus influenza isolates that we find in our nasopharyngeal samples, etc., etc. If you have an R, you can report it, but maybe you don't need to report S's and I's, and instead add a comment: if antibiotics are considered necessary, contact the microbiologist for susceptibility advice. I believe, and I hear many colleagues around who say that in their experience, the fact that there is a bug and 10 antibiotics with SI and Rs are considered an encouragement to treat. So I think from a stewardship model, it would be better to actually discourage treatment in many of these situations. My advice is to refrain from introducing local and national breakpoints. The old I lacked meaning and respect among colleagues. The system where only S and R meant anything was a very blunt system, and we can't afford a very blunt system any longer. The new I is logical and will gain respect if we take pains to explain and push it. EMA and ECDC trust that European countries act uniformly, and ECDC will no longer accept breakpoints that are not EUCAST breakpoints. If you decide not to follow EUCAST on the Pseudomonas issue, just to take one example, the system will break in other places, and national updating of the AST system will become more and more difficult. Semi-automated devices will not honor local or national recommendations. You will have to recalibrate zone diameter breakpoints to correspond to whatever you think is the right thing to do. And some colleagues will insist on following the European standard, and eventually you will have several systems in your country, and that will not be beneficial to patients. The National ASTU Committee was created to look after national aspects of the EUCAST system and to discuss with EUCAST and influence EUCAST and Nordicast. Trust the NAC and follow their advice, and influence them by informing them about your position. So before we go to the national presentations, I will have a few words on the ATU, because that's part of today's seminar as well. It's an alert in the laboratory. It stands for Area of Technical Uncertainty. You can take action or you can ignore it. Mostly zone diameter MIC correlates are excellent and totally unproblematic. So in the graph here, you can see the correlation between MICs for amoxiclav and Enterobacter, E. coli, Klebsiella, Klebsiella oxytoca, blah, blah, blah. All of them bunched together 325 isolates. And you can see that with the MIC breakpoint of S less than or equal to 32, R more than 32, there is no real problem with this test. And we have said that an ATU is not needed. Exactly the same distribution, same isolates, 325 Enterobacter, but now with the EUCAST systemic breakpoint, and you can see that that breakpoint does not work. There's overlap in the area of 19 and 20 millimeters, and that's why there is an area of technical uncertainty introduced for those particular millimeters, and we will discuss how to deal with that. But that's the reason why some of these will have areas of technical uncertainties. Here's probably the worst one, 531 Enterobacter from Piperazil and Tazobactam. And some of you will believe that everything is solved by performing an e-test or an MTS or something similar. It is not. This is a difficult agent. The only advantage of performing an e-test is you get a number with a lot of decimals. Doesn't make it more right. But at least you have a number and you have several decimals, and that will inspire you to think that you've got the right number. You can see the overlap at 17, 18, and 19 millimeters, and that's why the ATU in this case was introduced for those particular millimeter zone diameters. Here's a new agent which will be introduced shortly in the 2021 table, cefiderocol. The disc test is fantastic. It's much easier to read than any MIC test that we've seen so far. Broth microdilution reading really taxes your ability, and you will need a lot of practice to get the MIC testing right. So, my advice is to use the disc test for cefiderocol and then concentrate cefiderocol MIC testing to maybe 1 or 2 labs. If you do disc testing, there is an ATU. It hasn't been decided exactly yet, but let's say it's 18 to 22. And you can see that you will comfortably and reproducibly categorize E. coli as susceptible or resistant, and you will have a smattering of E. coli in the middle that you can decide to either ignore or to do something about. So ATU is not a susceptibility category. It doesn't stop you from reporting. It alerts you to a possible problem. It does not interfere with SINR. It's not to compensate for poor methodological skills. It's not a wide range of results. It's defined by a single MIC value, such as the 4 for colistin on Pseudomonas, or the 17 to 19 on Piperazil and Tazobactam, and actually probably 4 millimeters on cefiderocol. How the ATU is dealt with depends on the situation. The sample, the type of infection, the agent, the infecting organism. It corresponds to the gray zone that you use for many other tests in the laboratory. And just as the laboratory in one place thinks differently about gray zones than a laboratory in another place, you are now suffering from some confusion because you would like everyone to do exactly the same thing. And the problem here is that you cannot do exactly the same thing all the time, even inside the laboratory. And you cannot do exactly the same thing in Greece as you would in Denmark. You would have to have different rules for how to deal with the ATU. You can repeat the test, but that is only relevant if there was an obvious and identifiable reason for the failure. You used the wrong disc, the wrong medium, or something like that. Better than to say, I will confirm using an alternative test. That might be an e-test, an MTS, a broth micro, a PCR, PBP agglutination, whatever is relevant, but always repeat the original test. So if you end up in the Piperazil ATU 18 millimeters, always repeat that test and make sure that you next time have a zone diameter of 17 or 19. and compare that with the MIC. And more often than not, you will discover that there is a logical relationship between the MIC and the cone diameter. Report the result with a comment, or leave blank with a comment, or just discuss and explain with your clinician. And if it's a recurring problem, you should report it to your national AST committee, and the AST committee will then bring it up with EUCAST. Try to solve the problem if it's easy to solve, if you're requested to do so by a clinical colleague, if there are only few alternative antibiotics for therapy. In serious infections, a positive blood culture will merit more efforts than a urinary tract report. If it's a frequently recurring problem, you need to form a strategy for that frequently recurring problem. So far, so good. I think before we open up for discussion, we will now go to the national presentations. So I invite Ulrik to unmute, and I will show the first slide and only slide, Ulrik.
Yes. Just to shortly present the process that we've had in Denmark. In the spring of 2019, we had discussion in our Danish NAC, and everybody agreed that it was very important to involve stewardship people to secure the most optimal implementation of the new eye. Usually the stewardship people already have some kind of formal collaboration and relations with clinicians, so it was obvious to try to involve them in the process. So we had a meeting in the autumn with the Danish NAC and the stewardship people, and in general there was acceptance of the new eye, but everybody had to go back to their local region and discuss with representatives to be sure that it was accepted by everybody. So we had a follow-up meeting 1 month later, and the conclusion from that meeting was that 2 regions would implement the new eye, 2 would like to continue as usual, and 1 region was actually split in half between 2 departments wanted to implement the new eye, and 2 departments didn't want to implement the new eye. And although we've actually had a lot of follow-up meetings, that's still the current situation in Denmark at the moment. So the main concerns, and Gunnar has already mentioned this with meropenem and Pseudomonas aeruginosa, they have a concern that this might result in an overuse of meropenem, and also for ciprofloxacin for H. influenza. The stewardship people do not really believe that clinicians will understand the new eye or accept that it is actually something safe. So I don't want to go into any further details, so I think we'll just leave it at that. That's the situation in Denmark at the moment.
Thank you, Ulrik. I think we'll leave discussion for the end, so we won't discuss each country until everyone has presented, and then we can go back in the presentations if someone wants to bring up a specific slide. So I now invite Kaisu for Suomi, Finland.
Hello. Yeah, this is our situation is not much more clear than in Denmark, but there has been some progress. And the first issue was who was going to do this change or lead this change. In the beginning of this year, there was an effort to have a new, more official NAC, Finnish NAC, but because of Corona, it hasn't had any meetings by now, so it's still FIRE, which is very unofficial, who will lead this change in Finland and decide, or at least advocate the laboratories. We don't have any power to order them to do anything. Next, please. Yeah, last year, this time we had great plans on how to inform the medical community about the about the change. So we had made a session. How do you know that the antibiotic works? And there was going to be some talk about AST in general and a new eye specifically, and then also local infectious disease specialists to talk about the antimicrobial resistance issues. And we were happy because this session was accepted in all 3 events that were going to be this autumn. So it looked very good, but then all of these events have gone virtual. The Eastern Finland medicine event became Distant Finland medicine event, but it was carried out fully virtually, and we had this session, and it was very nice for us representatives at least. Then these Turku and Helsinki events also have gone virtual, but they were also shortened, and in that connection our session was cut out, so we'll have to wait for later events and apply again to have sessions. Of course, the first job to be done is to compare the local dosing traditions and regimens against the EUCAST dosing. And what is difficult here is that every hospital in Finland have their own antimicrobial use or antimicrobial therapy guideline, and they include dosing. So basically every clinical microbiologist should go through their own hospital's guidelines and see how the dosings are related to the EUCAST dosing. You can take the next one, Gunnar. And what comes to the common healthcare based infections, open ward infections, it's a bit more simple because we have these current care guidelines by the Finnish Medical Society, Duodecim, and there are usually what comes to infections, there have usually been also clinical microbiologists in the group. So if the doses may be up to date or may not if there have been changes like with Haemophilus recently. And then by going through these guidelines, we have identified one very Finnish problem. The very Finnish problems, it's a trademark of an American who have lived here for a while, and he makes a lot of fun with the problems we have. This is not one of his, but this is ours. So intravenous cefuroxime is our first line antimicrobial for almost any community acquired febrile infection. So when a person is admitted to a hospital, it's very often with vitamin jet. So he or she gets cefuroxime IV as empirical therapy. And we give it a lot. So our standard dose is this EUCAST high dose, 1 gram 3 times a day. And if we think about high dose, it would be 1.5 grams 4 times a day. So this, of course, raises question that in this context, should these wild type E. coli and others be interpreted S or I? I don't think we have really solved this as yet. There are different aspects, and the communication may be a bit difficult. And we can go to next one. Then we have had an sort of exception, a national way of reporting ESBL strains. Not all, but most laboratories have edited if there is an S for ceftazidime or even piptazer or any cephalosporin or penicillin for an ESBL strain, it has been edited to I. And now, since the new PIP-TASO EUCAST general consultation, there is an option if the strain is resistant to one or several third-generation cephalosporins, PIP-TASO should be given in high dose. So this is sort of very closely related to our idea of editing S to I. Of course, after removing the ATU with the new breakpoints, there will no be I category, but in this thinking, ESBLs could still be edited to I, and this is one question to decide on how to work further. And then we can go to the next one. So we have done some work on the comparison of the dosings, and this here I have collected what I found from my hospital's guideline, and Anu has also done a lot of work in Helsinki. So in general, it looks like IV dosing for penicillins, we tend to have quite high doses, and the range recommended usually covers both S and I. But what comes to per oral dosing, we, at least in the healthcare centers, they tend to only give twice a day, or recommend dosing twice a day. It's comes from some 10, 15 years back, and of course it's much more handy to parents if the child is in the daycare center. It's easier to give that penicillin in the morning and in the evening, but of course this is not according to pharmacokinetic pharmacodynamic system. This is not a good idea, and that there are campaigns going on 3 times dosing. Then of course hemophilus would still require high dose 3 times, and this is not currently in many of those current care guidelines for otitis, for example. Pseudomonas, at least in our hospital, there still tend to be low doses. I have been talking about this for several years, but still, when I in January saw the new version of our guideline, there was these rather low doses for Pseudomonas. The other side is that they always recommend 2 effective drugs for defined therapy. And the same goes for aminoglycoside. The dosing per kilo is lower than that's given in the EUCAST table, but we only use it in combination therapy with another effective agent, which of course may make it a bit different. That's the point or the thing, of course, in the new. And then we do have this issue with the Pseudomonas aeruginosa as everybody else. So this is the wild type Pseudomonas aeruginosa now, and in the right hand you can see how many eyes there will be exactly with the same strain. And the next slide shows that I feel that we really should be able to explain exactly what each eye means. And with our current LIS system, it won't be very easy, but the good thing is that during the last 10 years, we have been working with a new LIS, and it's the same LIS that is used by most big Finnish laboratories. It's a very typical Finnish public sector IT project. It takes years, and it's very painful, but anyway, it's now close to an end, and that will enable us to start with this new eye. And you can now take the next one, Gunnar. So this is the current situation. HUS-lab in Helsinki area, which is Helsinki is located here in HUS, and then they actually nowadays cover the whole south coast and a bit more to the Russian border. They will they will implement this new My Plus in beginning of next year. They are rather experienced in big IT changes. They changed the whole system recently, and that probably gives them or makes them brave enough to start with this microbiology 1-2. And in this system, there is really a possibility to code automated comments. So if you feed in the millimeter or MIC and then you get the interpretation I, the program will add a comment which you can word yourself beforehand. Back to the previous one, please. Yeah. And also this new program will give us some tools for ATU, because we can also have internal notes for the lab in a certain area, millimeter or mic range, and that of course corresponds to ATU. The older one only allows you to have these comments above a certain mic or below a certain millimeter. So South Karelia in the Russian border, southeastern Finland, they will start in February, and rest of HUSLab will follow in the beginning of March. And we also have scheduled for spring 21, but we don't have an exact date as yet. And now we can go to the next one. Yeah, and this is what HUSLab has planned. So they will have Teams infos to doctors in those respective hospitals. And then they will have links to dosing on the web page, and also these Nordicast Finnish and Swedish tables, or maybe an own reduced table. And then this was what we were planning, writing to Finnish Medical Journal in the beginning of January or February. It's a very slow journal, so I hope Helsinki people have started writing already if they aim at that schedule. And the next versions of antimicrobial guidelines in each hospital hopefully will be sort of synchronized with this new I. And Helsinki also plans that they will have lab reports to include a phone number where a clinician can ask for further information. And I guess that was about what I was planning to tell. Yeah, thank you.
Thank you, Kaisu. Excellent. And now we turn to the Norwegian jury. So Karianne and Kristoffer.
Thank you. Yes, we're just gonna give a brief overview of the implementation. We haven't really formalized any implementations or any guidelines in Norway. So we figured it would be nice to send out a quest back to find out different experiences from the labs in Norway. And then at the end, Kristoffer will show you how they technically have handled the ATU in their LIS system at the end. So we started sending out this month. Of course, very many are very busy with other things than bacteria. So thus far we have 14 responses, and then we're gonna make sure everyone will respond at the end. And what we've asked about are many different things. It's the experience and implementation of the new I category, ITU, and also a rapid AST of blood cultures and selective AST reporting. But the two last points we'll save for a different day. But the plan is, when we have all these answers, and very many come with comments, which is very good, because then you see, get a little more feel of what are really the problems, or what has actually gone well. So what we're going to do is try to compile everything and make a report, and also that AFA can come with some suggestions to implementations, and hopefully also that we can encourage the different labs to send in good experiences or what has been helpful, which may help others. So that's our plan. Okay, so when it comes to the I category, we asked, have you implemented the new I category in your lab? And about 75%, 2/3 or 3/4 have already implemented it. Some have not, or only partially. And how do you report? Now I can't see the whole top here. How do you report the I category to the clinicians? And very many use a standard comment, whereas some use the individually tailored comment, and then a few have marked other, where it's mostly that they have a standard comment, but they don't normally or maybe use it the whole time. What we do at our lab at the Oslo University Hospital is that we've always had a standard comment at the end of all AST reports that explains what SIR actually stands for at the bottom. But of course, I don't know how many clinicians read it all the time. So this was changed when we got the new I category. But in addition, since we want the clinician to understand the I and it's not implemented clinically very well, then we always, if there's at least one I in the AST, we always have an extra comment explaining the I. And we have a somewhat different wording when it comes to the wild type I's to explain that, try to explain that they're actually just as susceptible as they used to. It's just that they need the high dosing. And then this is an important part, I think, of implementation. And if you've had a dialogue with the clinicians before implementing the new I category, and I think most labs and microbiologists really wants to, but and we were planning on having lots of meetings this spring, but of course that didn't really work out well when the pandemic came upon us. So I must say, for my part, and I would imagine for many others, it probably hasn't been as good as planned. But at least many, and you can answer more things. Many have had meetings, many have had teaching or have like this, and then half of them have also had the written information, but then some have not had any at all. And there are many comments, and I've just selected a few. I think there's a great concern that many are afraid that the clinicians just, even if you have a lot of meetings and you try to teach, that it's very difficult to explain the new I, whereas others feel that this has gone quite well. So it probably depends on both the traditions of the hospital, how big a hospital, and also maybe some of the leading doctors that have the voice, if they're on board or not, I would imagine. And I think the other concern is that we can tailor and make great comments, but how many comments do the receiver actually read? And I think this depends on both the LIS system and how it looks in the report, and of course, how much time and effort the clinician has. But some at least feel that the implementation has gone smoothly. Some have said that, well, there were a lot of questions the first year, but now less questions. So, okay, so then over to the ITU. How many have implemented the ITU? At least quite a few, up to 80, and then some have not. And then also with the technical, is it possible? And about 50-50. Some say they have an LIS system that can handle the ITU, and others say no. And at the end, Christopher will show how they've done it. So what strategies have you chosen to handle the ATUs in your lab? And EUCAST, with what Gunnar presented, have many suggestions as to how you can handle it. And I think many labs use many of these. So very many use an alternative test when it's possible, or they report as uncertain, or they report as resistant, or they have other methods, which especially is not giving out the antibiotic. So some of the comments is about the technical part, where it's hard to handle the ITU and you don't have enough technical support. Another concern is it may be difficult to make really good guidelines, so it will be a little individual how you do it according to who's actually working that day. Some wish they had a good alternative test with the BMD. But at least it seems that, and now that we're going to implement more of the selective AST reporting when we finally finish this from AFA, maybe also it will be easier because you just choose not to report when you have many other good alternatives. Yes. So Christopher, you can.
Thank you, Karianne. So I'll hand over to Christopher.
Yes, thanks a lot. I will just briefly say something about how we at Haukeland University Hospital have implemented the ATU in the LIS system. And we realized quite early that we actually had to implement it or integrate it within the LIS system to be able to implement ATU at all, because we are used to work in a way that we record all zone millimeters or MICs directly into the LIS, and the categorization to SINR are done automatically according to the breakpoint tables within the LIS. So it would be far too cumbersome if we would have to recognize or realize that the result was within the ATU before we recorded the results into the LIS. So luckily, our German development company that develops the LIS for us, AlphaSoft, was quite eager and willingly to do this quite early, and we had actually the software changes finalized as early as February last year. It was finished. So next slide. Yes, thanks. This is just an example to show you. This example relates to Staph epidermidis and cefoxitin. And in this case, the result is within the ATU. As you can see, it is categorized as susceptible already, but it's marked with a different color to alert the technician that this result is within the ATU. And next one, Gunnar.
Sorry. There we go.
Yes. And when this is marked as an ATU and unresolved, then it's impossible for us to actually finalize the report. So we won't be able to make this as a final report and report this to the clinician without resolving the ATU. And this can be done as easily as just acknowledge the ATU and have it change color. But in the case of Staph epidermidis and cefoxitin, we usually do an MIC, PCR for MECA detection to resolve it. And the next one. So in this case, that was done with the MECA detected, and we could report the strain as oxacillin resistant. And the ATU, or the result that's within the ATU, is changed color to purple, and it's then possible to make the final report. Yes, thanks.
Thank you, Christopher. Very nice to see exactly how some LIS system can handle this. And I now turn over to, this slide is in the wrong place. I'm sorry about that. This is the Finnish nightmares. So we go to Sweden. Anna-Karin, welcome.
Thank you. Well, I'm mostly going to talk about the implementation of the new EUCAST definition of eye in Sweden. And I think as I have now been Swedish representatives in the Nordicast for almost 3 years, and I find it very interesting how different the Nordic countries actually are in the matter of implementing AST. And I think that this seminar has really taught me a lot of new things of how different our countries are. I guess the implementation in Sweden, we had some planned national activities for 2020. Of course, the Nordicast workshop in Gothenburg for all the microbiology laboratories. And then we had a planned symposia together with the National Association for Infectious Diseases and the National Association for Clinical Microbiology at the annual spring meeting, where Gunnar, Christian, and I was going to talk about the new I and ATU for both clinicians and clinical microbiologists. But of course, both of these events were canceled due to the pandemic. But we are planning to have the symposia at the spring meeting next year, hopefully. But what we have done this year is that the Swedish NAC, together with the Swedish representatives in Nordicast, has published a Swedish adaptation of the dosage sheet in the Nordicast Breakpoint table, which I think is a very good thing, because then we have a national strategy for the dosing. And you can find that document on the Nordicast website. And you can change to the next picture, Gunnar. Of course, this is just one of the picture in the document, but it's built the same way as the Nordicast, so that both the microbiology laboratories and also the clinicians should recognize the Nordicast Breakpoint table dosing sheet. Like you can see here that the cloxacillin is marked in red for the dosing for S and the dosing for I. And that is, just as in the Nordicast Breakpoint table, that means that there is an exception from Nordicast and EUCAST. So these are actually national traditional dosing. That's not exactly the way it is in the EUCAST Breakpoint table, but the NAC of Sweden has said that this is probably just as good at the dosing in the Nordicast Breakpoint table. I can see now, Gunnar, that I'm not sure that we have the last version of my presentation, but I will continue anyway. Okay, we can take the next picture. Since we didn't have any national activities this year, I was very curious about how far the new definition of I has been implemented in Sweden. So I sent out a question for all of the laboratories 3 weeks ago. And in Sweden, we have 21 regions. And in most of the regions, there is just one central microbiology lab, except for the more crowded regions of Stockholm and Västra Götaland, where we have more than one laboratory. So in total, we have 25 laboratories in Sweden, if I counted this correctly yesterday. So the results from this very short survey show that 12 out of 21 of the regions have implemented the new I and the Nordicast Breakpoint table of 2020 fully. And for four, no.
Sorry.
Yeah.
Oh, sorry. Here we go.
And for 4 of the 21 regions, they have implemented almost everything. And for some of those regions, the only thing that remained was the implementation of I for Pseudomonas aeruginosa, because there was great concern about the meropenem overuse in that bug. And 5 out of 21 of the regions are delayed in the implementation because they are on the way to have a new LIS, or they have problems implementing the new definition of I in the LIS, but mostly I think because they have been totally overloaded with the COVID-19 pandemic. So anyway, the regions that I have marked in yellow, they have all said that they should be able to implement fully until before the next year. And the ones that are orange here, they have said that they will do it during 2021. So in Sweden, there are no questions about implementing the new I definitions. All the laboratories already agreed to do that, and no one seemed to have any hesitation about it. It's just the speed of the pandemic now, I think, that will slow this work. Okay, we can take next one. And as I said, some of the regions that have not been able to implement the new I definition yet, they have had feelings that the antibiotic stewardship would be a great problem for reporting for the Pseudomonas aeruginosa. And of course, it is not, I used to show this slide to when I talk to orthopedics or the ICU doctors, and nearly all of them say that if they should choose one of these antibiotics from the report, they would probably use meropenem, even if they know what the I category now means. Okay, you can take the next picture. So we had quite some discussions in our lab at Karolinska University Laboratory in the antimicrobial susceptibility testing group on how we should proceed with this question. And what we finally decided was that we were going to do selective reporting for the Pseudomonas aeruginosa. I think there's a little, you can go one further, yeah. So for the wild type Pseudomonas aeruginosa, we only report 3 I's. We report for piperacillin tazobactam, for ceftazidime, and for ciprofloxacin. And the ID consultants and the information that we have given out to the clinician is that if we don't say anything else, then that means that this is a wild type Pseudomonas aeruginosa and the carbapenems are also okay. But if there's something with reduced susceptibility for the carbapenems, we will also report them. And we also decided that we would do this way of reporting Pseudomonas aeruginosa for all our clinicians and don't take into account if this is an ICU or an hematology department. And the purpose of this starting strategy, because I think that you have to keep in mind that this is just a starting strategy, but the purpose was actually to get more phone calls and more contacts with the clinicians in order to be able to have more discussion and more education over the phone about this matter. And most of our ID consultants, we have a lot of different hospitals that we work towards, but most of them has anyway thought that this is a good way to do it. Of course, not everyone in the university hospital, but I work mostly against one of the county hospitals where the IDs consultants have a very strong antimicrobial stewardship tradition. So in that hospital, they actually think that this has been one of the best things they have done because they have had more phone calls from other clinicians and they have been able to reduce antimicrobial treatment for Pseudomonas aeruginosa because they got more questions about this. So they actually see this as an opportunity to do more education, and that is nice to hear. And the reports back from them has also been that it's hard for them to understand, of course, the I fully. And I agree to that because when I read zones for Pseudomonas aeruginosa, you know, I still sort of jump when I look at the results because they look so mean, if you know what I mean. But I think that we just have to give it some time and it will settle because all the changes we have made so far, they settle. But you have to do a lot of education and you probably have to change your strategy when you see what the results are. So now we actually are talking about that maybe it's time for us to start to release the carbapenems to special wards like the hematology department and the ICUs and so on. So this is not the final way to report Pseudomonas aeruginosa and the I category. But I would also like to say that we have not just one comment in the report, we actually have 2 comments. One general comment at the bottom, and then one more comment on top, just to make sure that they really read the comments. And I would just like to say that regarding ATU in Sweden, the Swedish NAC has made a survey where there was not 100% of the laboratories that answered that question, but at least 90% of the Swedish laboratories have implemented the ATU. And the biggest problem that I think we all feel with the ATU at the moment is the Enterobacterialis and the Pyrrhosyl tazobactam, which probably will be solved, not 100%, but will be much better in the next breakpoint table. So that is good. And then we have the problem with the ciprofloxacin and the Enterobacterialis ATU, but I think is the biggest problem at the moment. And in our laboratory, we had chosen not to act on the ATU for ciprofloxacin. We will probably have to change that strategy next year, I think. Okay, Gunnar, thank you.
Thank you, Anna-Karin. I now call on Iceland. I'm not sure Iceland is with us. Is Iceland with us? And I've written here 0 or 100% because there's one lab in Iceland. So if one lab has changed, that's 100%. And if it hasn't, that would be 0%. And this is where I would have expected you to laugh a little bit, but I can't hear you. So I have no idea whether you thought that was funny or not. Anyway, thank you very much for excellent presentations, all of you, possibly excepting Iceland. I think this is how we do it. First of all, I would like the presenters to afterwards send me a brief email in which they say that it's fine to put your presentations on the Nordicast webpage, because I think a lot of people would like to go back and read some of those solutions and strategies and ways to handle things that you have presented. I think many of them were excellent. So if you are okay with that, I think it would be good to put the actual PowerPoint presentations on the Nordicast website. That's one thing. The second thing is that we are recording and the recording of this seminar will be available probably after the weekend. So the third thing to say is that you can, of course, ask questions through the chat. But you can also just unmute and ask your questions directly. When you do, can I ask you to address your question to one of the presenters? So you could say Gunnar or Anna-Karin or Karianne or Christopher or Ulrik or whatever, Kaisu, etc. And that will make it easier to know who the question is addressed to, and for that person to jump in and immediately start replying to that question. So with that, I open for questions.
Yes, Gunnar, should we say that it's okay, just like we do in the workshop, to do the question in our own national language and you sort of translate? Or?
Yeah, that's fine. If you want to use your Danish or, well, Icelandic and Finnish is a bit difficult, but otherwise fine. And if you prefer to use the chat, that is also okay. And there's already a general question from Camilla to everyone. A general question about Pseudomonas aeruginosa and UTI treatment when ciprofloxacin is reported as I. Is normal dose sufficient here, or should you use the high dose? So who would like to grapple with that? Anyone? I can start by saying that Anna-Karin pointed to the, let's call it problem with the ATU for ciprofloxacin on Enterobacterialis and especially E. coli and Klebsiella pneumonia. And I think that particular problem points to when the ATU or the need for a ATU can be blamed on the Breakpoint committee having made a terrible choice. That breakpoint is a crap breakpoint. If you cannot live by a breakpoint, the Breakpoint committee failed. So the discussion has already started in EUCAST, but the change will not be implemented in 2021. But the discussion has started as to whether we need urinary tract breakpoints for ciprofloxacin, which may be higher than the 0.5, 0.25, 0.5, and systemic breakpoints, which may be lower than the current breakpoint. And in that way, we could actually probably do away with the need for an ATU for ciprofloxacin and E. coli, Klebsiella pneumonia. The piperacillin tazobactam ATU will probably be reduced somewhat by the change of the breakpoint from 8.16 to 8.8. But having gone through the data actually yesterday, we are agreed that we still need an ATU because it is a difficult test. So it won't disappear completely, but it will be reduced. So who would like to say something about Pseudomonas and UTI? Christopher, can I invite you to deal with this?
Yes, you could.
You
I
could
think
say
that
no
is...
if you don't want to.
No, that's okay. As this is increased exposure, I would say you could perfectly well use the standard dose for treating a UTI with Pseudomonas when it's reported to eye. You will then achieve the increased exposure in the urinary tract.
Yeah. Yes, absolutely. I would also maybe add that, Pseudomonas in a urinary tract infection may be just colonization. It may be a rather banal urinary tract infection, or it could be a sign of something much more serious. So if you intend to sort of treat a Pseudomonas in urinary tract infection, you need to make up your mind as to which of those three you're dealing with. And that will influence whether you give something, how much you give, what you give, and for how long you give it, and whether you need to take other corrective measures. So there is a question from Aarhus. For Pseudomonas, could we report only imipenem, wild type is I, and not report meropenem? Meropenem could be tested for detection of carbapenemase, but not reported. So you didn't address this to anyone specific. Anna-Karin, can I ask you to deal with it, because I think actually one of your slides did show what you think is the correct way to deal with this.
Yeah, well, the way I have learned this is that the meropenem is a better choice for treating with, if you should treat with the carbapenem. So I definitely don't think that you should leave out the meropenem, because there's a risk of resistance development and so on. But maybe you can say something more about that, Gunnar.
Anyone else want to butt in and have an opinion here? I tend to agree with you, Anna-Karin, that if you decide to report carbapenems at all in the first instance, you should probably report both. Meropenem is a more active agent than imipenem, and you probably create more disturbance gut-wise and resistance-wise, etc., by just reporting imipenem. Personally, I think your model here with reporting the eyes for PIP, SAFTA, and Cipro is excellent. Always to test for meropenem and imipenem and the others, but not necessarily always report them face blank, but to retain the results. I think it's important that the report that you send out actually indicate that there are more results for anyone who actually needs them. But that is easily solved. Otherwise, I think this has the advantage of actually teaching people about the importance of the eye and how to deal with that. Anyone else?
I could just say that I agree with the I really fancy the way the Swede Anna-Karin has chosen to report the Pseudomonas aeruginosa. It would trigger the clinician to actually think.
Yeah,
it's very good.
And I think you should think along the same lines when it comes to a number of other bugs that we have sort of traditionally reported without really thinking much about what we're doing. I think one of the reasons no one thinks it's relevant to increase the dose for Haemophilus influenzae is because 90% of the Haemophilus influenzae that we actually do report from upper respiratory tract infections are not in need of antibiotics. So everyone think it works fine when they give, a substandard dose or a sub-active dose, because you will never really get bothered by the fact that you would have a failure. So if the infection is insignificant, how can you have a failure? Arnfinn has sent me a comment or a question. Should we expect that the ATU will expand to more drug-bug combinations as we gather more experience with a new I category? I think yes and no. I don't think it's related to the I category or the new I category. It's related to two facts. One is that last year when we introduced the ATU, it was sort of a trial period where we said, let's not introduce 252 ATUs because people will be even more confused and desperate. I think as people learn how to handle the ATUs, there is good reason to introduce a few more ATUs here and there, because there are more areas where it is difficult to actually take responsibility for the result when you end up in that specific area. Cefiderocol is a good example. Ceftaroline on Enterobacterialis is a hopeless test, not because we didn't try to make it very much more useful, but it just doesn't work. Some people will say that tazobactam is a hopeless inhibitor, but that's not quite the case, because if you look at ceftolozane tazobactam, that test has no problems whatsoever. So it's a combination of inhibitor, getting the concentrations right, the original beta-lactam, etc., etc. So the answer is yes, I think there will be a few more ATUs for 2021. Some of them will shrink, if you like, instead of 3 millimeters, maybe 1 millimeter. There will be no ATU which covers more than one MIC step. And there will not be a huge flurry of ATUs. We're discussing 1 or 2 or 3 or 4 more than the ones we currently have. I hope that answers the question, Arnfinn. So who's next? There are 78 of you out there, 77 if I don't count myself. There must be some questions. Is there a slide that you would like to see again? Because then I'm happy to back up and find that slide for you. And I agree with Radar Jetland, who writes over the chat, part of the problem is making, yes, part of the problem is making clinicians understand the new I is that many relate it to the old I. And, you know, what about changing to a different letter? And I think I answered that question. And even those inside the EUCAST steering committee who were most in favor of changing the letter 2 years ago when all of this started up are now absolutely against trying to change the letter. It is going to be really difficult with LIS systems, and different LIS systems will deal with it in different ways. Different semi-automated devices will deal with it in different ways. And the result of all that will be that over a long period of time, probably at least 5 years, possibly more, we will have S and R and I and the new letter, whatever that is. You suggest an H, yes, for high. And it will actually work in French as well, and in German for hoch. So yes, it could be a possibility, but we will have 4 categories floating around for 5 to 10 years. And I don't think that's what we want. Anyone else? Happy to back up through the presentations if there is someone who wants to see another slide.
Gunnar, this is Arnfinn in Tromsø.
Hey, Arnfinn.
Could you go back to the Cefiderocol slide?
The one I showed.
It may be very specific and very particular, but it is, of course, an interesting drug when it comes to multi-drug resistance and last line
Absolutely.
antibiotics.
Here you go. Can you see it?
Yeah, I can see it here.
Good.
So to start with the let's say the recommended test, you recommend this diffusion, yeah.
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 For routine laboratories, I would say that since this is an antibiotic that will be relevant for multi-resistant gram-negative bacteria and not really for anything else, you will not have the practice that you need, because you will do this so rarely. You will not have the practice that you need to properly read broth microdilution panels. If you're willing to waste a lot of money by practicing and read maybe 20 panels for every one real panel, then fine. If you're not prepared to do that, the message that I try to send is that the disk diffusion test is actually, and a bit surprisingly, totally unproblematic. And my recommendation would be for routine laboratories to use the disk diffusion method for cefiderocol. Make sure that your distribution looks very similar to this, that you have a median or a mode of your wild type, which is somewhere in the vicinity of 28-30, because then you've got it right. And then to trust the breakpoint and perhaps introduce the ATU. And then on those few occasions when you actually absolutely need a result, you can send it off to Arnfinn or to Växjö or to, wherever you can get that service. And until people have had time to organize themselves, the Växjö laboratory do broth microdilution on cefiderocol. We have cefiderocol panels that are commercial panels, that are frozen panels, reference frozen panels, and we have correlated all of those together with discs from 2 manufacturers. So we're pretty certain what we do, and the ones that are in that ATU, yes, they are in that ATU, and they are difficult. So if you're going to use this test, you should honor the breakpoint and call those that are below the breakpoint resistant until you have further evidence. Does that answer your question, Arnfinn, or was there a follow-up question?
Yeah, I have a follow-up because it's quite new drug principle in a way, because it's dependent upon, let's say, active transport and based upon a iron binding motif.
Yeah.
And that means that the physiological state of the bacteria is very important to have, let's say, you probably have to be very careful with how you prepare the AST in particular. Yeah.
Yeah, and especially the broth micro, that is of utmost importance. Whereas the iron dependency does not influence the Muir-Hinton plate test at all. I think the companies are about to solve the different difficulties with the broth micro test from the point of view that they now have incorporated everything you need in the broth micro test that you buy from Sensititer or Merlin or whatever. So you don't need to fiddle around with your own iron depletion and adding iron to the final broth, because that would have made it even more difficult. But it's still a difficult test to read. And one of the reasons why EUCAST took more time, actually a year more than we would otherwise have done, was that we didn't trust the MICs that were presented to FDA and to CLSI. And it turned out that we were right, because the background material that the company presented was read over time with 2 different instructions for how to read endpoints. And that caused MIC distributions to become surprisingly wide, whereas zone diameter distributions were exactly the same as we are used to seeing for any old cephalosporin. So we realized that there was something fishy going on, and we insisted on doing everything from the beginning, and it turned out that we were right, and the MIC distributions that we're now looking at are actually the new MIC distributions performed with 1 reading instruction only.
Just one brief follow-up. Do you see any species difference in distribution within the Enterobacterales group?
Not much, but to be quite honest, we've mostly looked at Klebsiella pneumonia and E. coli simply because these are the ones that are mostly presented as multi-resistant. We have looked at lots of Acinetobacter and Pseudomonas and Stenotrophomonas multifilia. And as you will know, the breakpoints are valid for E. coli, Klebsiella pneumonia, and Pseudomonas. And all of those three are equally easy to handle with the disk diffusion, equally difficult to handle with broth microdilution. And then for Acinetobacter and Stenotrophomonas, there weren't enough clinical cases for the company to obtain a license for those two bugs. But quite honestly, the agent is extremely active against Acinetobacter and also against Stenotrophomonas with MIC values which are down in the area of 0.016, 0.03, up to 0.12, 0.25. So there is good reason to think that Acinetobacter or Stenotrophomonas, when up against a wall, would be good targets for Cefidrochol. And we have published the ECOFs, so it's actually quite easy to determine whether an Acinetobacter or Stenotrophomonas is wild type or non-wild type. And I would have said that a wild type of either of those two would be a target in a tight spot.
That's good to know. Thank you.
But honestly, we don't know much about Hafnia, and we know very little about Klebsiella ozanae. So there are, some bugs that we know little about. There is another question here from Galaxy A3. What is your experience after changing reports for aminoglycosides? Our neonatal department still uses TOBRA plus PCG, and I'm sure you're not alone with that. So can I task, who should we address? Who would like to answer that question? Kaisu, would you like to address it?
I can say something from Norway.
Okay, good.
That we have decided to just wait to do anything with aminoglycosides. And here's one of Anna Karin was pointing out that even if we're up in the north and we have many similarities, there are also very many differences, especially in some of the ways we use antibiotics. So when it comes to aminoglycosides, it's mostly Norway and Denmark that has it as routine use. I'm sure in the neonatal care you also use it in the other countries, but as a whole. And it's such an important backbone in our sepsis and also other types of treatment that we are working in AFA to collect data and also make a paper writing a little about it in our Norwegian Medical Journal. So we haven't landed on exactly how to do it. So I think most laboratories still reports it. Some might use a comment in addition, but we have so much clinical experience from so many years that it would just, it would make an uproar, I think, if we suddenly took it away. So in Norway, we've just asked everyone just to hold on, and then we'll try to find a good national strategy.
I think maybe the most important thing with aminoglycosides in relationship to breakpoints and the changes in breakpoints is to try to do away with gentamicin for Pseudomonas. Gentamicin is substandard for a Pseudomonas infection. And if you go to the website, the EUCAST website, and you look at the MIC distributions for gentamicin and tobramycin on Pseudomonas aeruginosa, you will realize that you need to actually reach at least 8 milligrams per liter to encompass the wild type for Pseudomonas aeruginosa with gentamicin, whereas tobramycin, it's still a tough task, but the ECOF for tobramycin is only 2 as compared to 8 for gentamicin. I can see no reason whatsoever for using gentamicin on Pseudomonas infections. There is no advantage whatsoever, except possibly that you have gentamicin in your right pocket and tobramycin in your left pocket, and you think it's more difficult to get hold of the tobramycin in your left pocket. Otherwise, I can see no reason not to do away with. I had a long discussion with the Irish yesterday, and they said, but all our machines can only determine gentamicin concentrations, which is of course a ridiculous argument, because all of the machines that can determine gentamicin can also determine tobramycin, but you have to talk to your manufacturer or whoever is delivering your stuff, and you can buy the tobramycin stuff instead of the gentamicin stuff. So that's what you need to do in that case.
Could I have a comment as well on this question, Gunnar?
Absolutely.
Because we don't report the aminoglycoside SINR anymore. And we have the same problem as Galaxy A3 with the neonatal department. And we've had some discussion with them because they see this as an antimicrobial stewardship thing, that they should be using benzylpenicillin together with amikacin. But we have discussed that, and as an empirical therapy, when most of the kids that they get into their department does not have an infection, a bacterial infection that needs antibiotic, this is the way they do it empirically. But when we have a bug, when we have a Staph aureus, then we are trying to make them to understand that they cannot be using the aminoglycoside for that. They have to change the antibiotic treatment. And I think this will be a long process, but I think that it's okay to use the combination for empiric treatment. But as soon as you have a finding, then you probably should not report as an SINR. When they call us and definitely want to have a report on the aminoglycoside, we have a discussion with them, and then we give a comment instead, saying that the isolate does not have any resistance mechanism and is in the wild type distribution. And I think that the more they call us and the more we talk to them about this, is probably going to be a change in the future. But for empirical treatment, when you are uncertain if there's an infection that needs treatment or not, this is, of course, you can still use it out of antimicrobial stewardship point of view, I think. But when you have a bug, should you be reporting them then? I don't think so. Okay.
Thank you, Anna-Karin. Anyone want to get involved in that discussion?
Yeah, I'll give the word to you, Barbara. I just want to say one thing when it comes to children and neonatals, because all the PKP data that you use your breakpoints are on grown-ups and not children. So to be adamant and say, oh, you can't get the concentrations due to PKP data, you can't really use that adamantly on the small children and neonatals. So I just, yeah.
Before we let Barbara in here, can I just say one or two things? One is in reply to Radar Jetland, just to say that I agree with you in that, you know, taking away knowledge from highly intelligent and well-educated people is really difficult. It's the most difficult thing you can do, and there is actually lots of science on that. That taking away knowledge, the more intelligent and the more well-educated a person is, the more difficult it is to deprogram them. So yes, it is difficult to introduce the new I because you have to take away the old I. But I also think that if we say, well, you know, everything we learned from let's say 71, when I started in microbiology, has to stand, come hell or high water. It is automatically true because it's always been there. Then we will never get anywhere, I think. So I think it's time for everyone to actually pull together and realize that this gives us all an opportunity to fine-tune therapy in a better way than we have in the old days. So that was one of my comments, and I've forgotten what the other comment was. So I will now let Barbara.
Thank you.
Online.
Well, I just wanted also to stress the point that in Denmark we use aminoglycosides as short-term empiric therapy together with the beta-lactam, which of course then can result in monotherapy of aminoglycosides if you've got an Enterobacterialis, for example, which is ampicillin non-susceptible. And we have discussed that both in DANRISM and also in Nordicast. Another point I want to make here when we come close to the ending of the session is that we will send out evaluation forms to you via email. I'm not sure yet if that's going to be in the next week for the first 2 seminars, and then after the 3rd seminar a different one, or if it's going to be one evaluation for all the 3 webinars together, but they will come.
Excellent. And I've now remembered what my second comment was, and that was for anyone who's really frustrated about the aminoglycosides, I think it would be a good idea to read the 120-page document on aminoglycoside, modern PK/PD, and what you can expect from these agents when it comes to pharmacokinetics, pharmacodynamics, variation in populations, etc., etc. And that document is available online. If you can't find it from the EUCAST webpage or from the Nordicast webpage, drop me an email and I will make sure that you get the link to it. It's a PDF document, and it is an excellent report based on all the most recent data you can find for aminoglycosides. So I really encourage you to read that. That's it. I think anyone else wants to say something before we end? There are still 56 participants out there. Anyone wants to say something before we end?
I would just like to say that I think that it's regarding all the hard work we have done with the pandemic this year. I think these are great results for the Nordic microbiology laboratories, that we have actually managed to do this really big change in the way we do our AST reporting. So
I think that's very true, Anna-Karin. Thank you very much. I think everyone should be really proud of what they managed to accomplish. Right. I think that's it. It's Friday midday. I'm sure we still have some work to do, but then we can go into the garden and plant plants and bulbs and what have you not. So take care, stay safe out there. Don't do anything silly. Have a lovely weekend. Bye, everyone.
Goodbye.
Goodbye.
Goodbye, everyone.